course content. I think it says resource material for week 2. One is a slide set of baby characteristics for newborn assessment. So there's about 90 slides. They're all tagged, and they all show pictures of babies doing different things, having different things, pooping different things, eating different things, doing all kinds of things that babies do. And I would strongly suggest that you go through those slides. There's 90 of them. I don't have time to go through them here. They're a supplement, but they will assist you when you are assessing your babies. And since that is one of your assignments for clinical, it wouldn't be a bad idea to take a look at them. The other one is a narrated PowerPoint presentation on fetal monitoring. It talks about every single thing that you guys need to know about fetal monitoring for both quizzes, finals, and just to function in clinical. There are some glitches in the narration that I have tried to edit a number of times, and they just don't seem to iron out. But if you read the slides and listen, you'll get the material. We'll talk a little bit about fetal monitoring today because I have just basically an activity for you to do. We may get a chance to do it today. I may send it home with you. It's up to you to do it. It's useful. It'll help you understand fetal monitoring. If you choose not to do it, that's up to you. But the answers for it are on Blackboard as well. Okay. I feel at a really strong disadvantage because I don't know everybody yet. It takes me a couple weeks to meet everybody. So if we can everybody just say your names, that would be very helpful to me. Okay? Starting over here. Beatsy. Beatsy, okay. Loud. Okay. Dominique. Okay, so let's start back here in the back row.
Jimmy.
Okay.
Nicole. Tina.
And over here to the Linda. Okay.
Jessica. Kathleen. Sarah. Tina. Laura. April. Louisa. Mary Louise.
Dawn.
Jenna.
Okay, well, let's skip over to this side then. Go ahead, I'm sorry.
Jennifer.
Okay. I know Blaine. Okay, and now, please go to you.
Erica.
Can you tell me your name?
Aisha.
Okay, thank you.
Jennifer.
Lady.
Okay, and down here?
Will.
Okay,
Abraham.
I know you, Abraham.
Ryan.
Okay, and you are?
Ahmad.
Okay, thank you very much. I just appreciate it because sometimes, especially when I'm passing out quizzes, I'm yelling names. It's helpful to have a face. All right. So how many of you guys saw a delivery in clinical this week? Oh, good. Oh, a lot of people. Excellent. Okay. How many of you saw a vaginal delivery in clinical this week? Oh, very good. Okay. Well, sometimes we don't have so much luck there. All right. So today when we're talking about labor, we're going to be talking about the process of labor with a vaginal birth. All right. And we're going to be talking about it in terms of what typically we would expect to happen from a physiologic perspective and from a behavioral perspective and what's going on with the baby, etc. All right. I always hesitate to use the word normal, but there's basically 2 ways to have a baby, and the way that we're designed to have a baby, if you're female, is through the vagina. And so this process is one that all women who are delivering vaginally are going to go through. The process is going to vary in terms of their perception of it and in terms of perhaps problems with it and in terms of how the baby responds to it. But it goes in stages and phases, so you've got to complete one stage or phase before you move on to the next one, okay? And if you don't, then there's a problem with the labor, and you'll be talking about that in week 5 with Professor Van Meter. The other way to deliver a baby is by cesarean section, and I would imagine that if you haven't seen a C-section yet, you will see one before you leave the course, because there's an awful lot of them out there. But today we're going to talk about sort of the normal process, and we're going to mention medication, but we're also going to talk about the unmedicated process, which happens a lot more as well. Okay, not everybody sees an unmedicated birth during this course. How many of you guys that saw vaginal deliveries had patients who had epidurals? Yeah, that's most everybody. Did anybody have one that had no epidural? Okay, all righty. And was that mom's choice?
No.
Okay, I didn't think so. How about you?
I think it was the mother's choice.
Okay, and how about you? Mother's choice, okay, yeah. Most women that we see in hospitals today are going to have some kind of medication with their delivery. And if they don't, it may be because, Linda, can you let Patsy in back there at the door? It might be locked, I don't know. She right there? Oh, she went up the back stairs, okay, all right, well, God bless her. It may be mom's choice, but it may also be because of the timing of when she arrives, thank you, in the hospital and how her labor's progressing. Okay, so we'll talk about how we talk about pain medication. But basically, let's start by thinking about what labor is. All right, labor's a process. The reason it's called labor is because it's a lot of work. When you compare it in terms of the energy expended, people compare it to running a marathon, 26.2 miles. So it is a significant task for the body to accomplish. And in that process, basically what's happening is the fetus, and sometimes I refer to the fetus as the baby just because they're kind of interchangeable to me at this point in time. But the fetus, the placenta, all right, and the membranes, the amniotic membranes, are going to be moving out of the uterus, through the pelvis, through the vagina, and out into the world. And so in order for that to happen, some things have to change. And the changes that we are anticipating are going to occur in terms of the cervix, which has to open in order for the fetus to be expelled. And the uterus changes in terms of its behavior because it starts as a relaxed sort of sac of muscle and it begins to contract, and then it contracts more strongly and more strongly and more strongly. And then the patient is having incredibly powerful contractions that are going to expel this fetus out of the body. And then the position of the fetus has to change as well, because the fetus starts up here in the uterus and it ends up, down here out in the world. So it's got to do some movement itself. So that whole process is what we think of as labor. And so basically those changes are what we see happening during labor, all right? Changes in the cervix dilates or opens. Changes in the cervix in terms of effacement. Instead of being long and thick, like my two thumbs together, which is kind of what the cervix is, long and thick when we start, it becomes very, very thin, and the cells shrink so that there's no damage to the cervix during the birth. And then there's that progressive descent of the presenting part, what's coming first, through the pelvis and the vagina. And please stop me if you've got questions, okay? Because I will keep plowing ahead. Basically, what happens in terms of why labor starts is that during the 9 months of pregnancy, the maternal body is trying to keep the pregnancy inside the uterus because the uterus is the ideal place for the fetus to develop. And we'll talk in a couple of weeks about preterm labor and preterm babies. But really out in the world is not where they belong, okay? And if you get a chance to go to the NICU, you might get a chance to see some of these very little preemies and the ways that we try to mimic the uterine environment so that they can develop and grow. But we don't do a particularly great job of it. I mean, they really need to be inside the uterus. So the maternal body tries to keep the pregnancy inside. And when labor starts, basically those factors that are keeping the pregnancy inside are overridden by factors on both the part of the mom and the part of the fetus saying it's time for this baby to be delivered. And in terms of the maternal body, progesterone, which relaxes smooth muscle, is what keeps that uterus nice and relaxed and soft and calm during the pregnancy. Right? And estrogen is the hormone that is secreted that increases uterine irritability. So at the time of term, which is somewhere between the end of the 37th week and the end of the 41st week, okay, at the time of term, that ratio changes. And progesterone becomes less powerful, let's say, and estrogen kind of asserts its dominance and becomes more powerful. And that increases the irritability of the uterus, so it will contract. And along with that change, there's other changes that go on in the mom's brain. the posterior pituitary starts to secrete increased amounts of oxytocin. Women, well, everybody secretes oxytocin, but they secrete it in non-labor amounts, okay? We all secrete it during our lives. It's what bonds us to other people. It's sort of the cuddle hormone. But during labor, there's an increased secretion of oxytocin, and that causes uterine contractions. And it also causes letdown of milk into the breasts once the mom needs to feed the baby. There's also prostaglandins, and those are released by the fetal membranes. So the fetus and the membranes that surround the fetus, which are a part of the fetal cells, they start to secrete prostaglandins. The fetus secretes fetal adrenocorticotropic hormone, and what that does basically is that's the part of the fetus that kind of turns down the maternal progesterone. So the fetus is giving some feedback signals that say, I'm ready to be born. And then of course the fetus is big. You know, as the fetus gets bigger, I mean, the uterus can expand amazingly. And if you've ever seen pictures of moms who are carrying, you know, like 6 or 7 multiple gestation, lots of babies in their uterus, we know it can stretch beyond the bounds of what we can possibly imagine. But still, it does get irritable, and it does respond to that irritability and that stretching by starting to contract. So all of those things kind of converge all at once, hopefully when the fetus is termed, and say to the body, you know, it's time for the fetus to be out and the pregnancy to be over. And so that onset of labor occurs at that point. Any questions? All right. Yeah.
You said when the fetal secretes adrenocorticotropic hormone, it turns down something, and I missed what you said.
Progesterone.
Progesterone?
Progesterone.
Thank you.
So how does a mom know that she's going into labor? Well, you know, sometimes it's incredibly obvious because her bag of water, her membranes, fetal membranes rupture, and she leaks all the way down her leg and, you know, forms a puddle on the floor. And that's usually a very good indicator, regardless of what gestation she is, but hopefully, again, she's term, that she needs to go into the hospital and be evaluated. And we'll talk about why for a number of reasons in a minute. So that would be that rupture of membranes down at the bottom of that list. But oftentimes it's a little more vague than that, and particularly if the woman is a first-time mother, she may not have a sense of what labor actually feels like and when she's actually going to labor. So any kind of twinge or, you know, discomfort or pressure or anything like that might be something that makes her think, oh, well, this could be it. Oh, okay, well, let's just troop on into the hospital and check it out. And so sometimes first-time moms have a couple of trips to the hospital. That's why lots of times they're told to call their physician first, and they're evaluated in the physician's office, or they might be evaluated in a triage portion of a labor and delivery unit. Okay? So if we're talking on the phone to a mother who thinks she's in labor, these are the sorts of things that we're looking for. Okay? Lightening is something that we see in primipes. And what's a primip? Or primigravida?
First pregnancy.
First pregnancy, or first primigravida is first pregnancy ever. Primipara is what? Anybody know what the difference between primigravida and primipara is? First time past 20 weeks, right? Okay, so parity has to do with deliveries past 20 weeks. Okay, so lightening basically for a first-time mom who's delivering a baby after 20 weeks, or a first-time pregnancy ever, has to do with the baby who's been floating kind of up here in the uterus for, you know, 8.5 months or so, or 8 months, basically drops, and that's basically what we call it drops. In other words, their presenting part, which is usually the head, drops into the pelvis. And it essentially kind of gets things started. It makes sure that this kid can fit through this hole, which is an important consideration. And for the mom, it also kind of gives her a little room under the rib cage, but then it also means that the baby is sitting right on her bladder, so she's going to feel like she needs to urinate frequently. So lightening occurs in a primigravida or a primipara to kind of prime the pump, okay? You don't see it occurring in multips, which is someone who's already delivered a baby, right? Multipara or had multiple pregnancies that they've been able to deliver. Multiparas typically have lightening at any point in time during labor, all right? So it can come at the beginning of labor, in the middle, towards the end. But if it's a first-time mom, you want to ask their gravity and parity, if you're talking to them on the phone, just to get an assessment. And then say, well, do you know if the baby has dropped or has the baby gone into the pelvis? Their healthcare providers probably told them because it usually happens a couple weeks before. And so that's a good indicator that things are starting to, at least we've made some progress. We at least have a baby in a pelvis, which can be a big accomplishment. Cervical changes, that's important. And it may not be something that the mom can particularly assess on her own, but what we want to know is, does she think she's past her mucus plug, all right? And, let's see. So basically, if this is my cervix here, all right, I know it's shadowed, but the mucus plug is a thick, viscous, mucusy kind of glob that basically seals off the cervix like a cork. And the mucus is bactericidal, so it kills bacteria that might try to crawl up into the uterus. And as the cervix starts to change, this mucus plug basically kind of sloughs off. And it's just basically passed off as discharge. And it's usually clear, and it occasionally will be pink tinged, all right? Because as the cervix does change, little capillaries in the cervix start to break, and we do have little flecks of blood, okay? This is different from bloody show, and I'll define that later on. But a mucus plug passing oftentimes looks like clear, viscous discharge with maybe some pink tinges in it, and the mom may have recognized that she has started to pass that. Braxton Hicks contractions are basically practice contractions, and maybe she's been having them for a while. They don't really dilate the cervix, okay? So that brings us to an important point, which is what's the difference between true labor and false labor? All right? What do you think the difference is?
When the cervix is dilated.
When the cervix changes, we have true labor, all right? So true labor contractions change the cervix. They efface and dilate the cervix. Braxton Hicks contractions don't change the cervix. They basically, it's like a pitcher warming up before a game. It's the uterus getting in shape. It's just practicing its contracting so that it'll know what to do when the time comes. Yeah.
Does the mucus plug concurrently come out when there's a ruptured membrane, or does it come out first?
It can come out first.
Or concurrently
Certainly,
happen?
if there's membrane rupture and there's a big, huge gush, some of it's going to come out.
So it can go either way?
Yeah.
All right.
We talked about ruptured membranes. Another thing that happens as these hormonal shifts start to occur with mom, that we talked about, estrogen, progesterone, etc., is that mom does tend to have a spurt of energy, and that's actually not an old wives' tale. They do tend to feel a little more energetic and a little bit more perky, like they're going to get some things done, and sometimes they do. And it is kind of, as that hormonal shift happens, there is this sort of surge, and that may not be a definitive indicator that labor's starting, but it's important to notice, if they've been feeling a little bit more energetic and a little bit like they've got a little bit more pep, and it's in conjunction with some of these other things, then yeah, maybe labor is starting. And then GI disturbances. Oftentimes moms, as they're going into labor, will have, they may have diarrhea, they may have some vomiting, okay? They may feel like they ate something funny or something like that. Basically, the body is just trying to empty itself out of anything that it doesn't want to have to deal with as it goes into labor. So the stomach empties, the gut empties, all right? And there's a hormone called relaxin, and relaxin, right over here, R-E-L-A-X-I-N. Basically what relaxin does is it kind of facilitates relaxing the joints of the pelvis, so there's a little bit more flexibility to them. But the other thing it does is it can kind of relax the gut and decrease motility and sort of empty everything out, particularly if the mom is starting to have some contractions. So we'd be asking a patient about these things. We'd be looking for these as signs. And certainly if she's got a collection of them, and definitely if she's ruptured her membranes, then she needs to come in to be evaluated. So we would say, come on into the hospital, bring it on in. All right, now what I'm basically going to do is I'm going to talk about a bunch of terms that you may see in a chart, all right? that you may hear spoken when your healthcare provider is talking about labor, that the nurse may discuss, etc. But hopefully they'll help you to understand the process, because we kind of think about the process of labor to a certain extent from the perspective of the fetus, because the fetus is the one that we've got to get out of the uterus, okay? So there's things that have to do with the fetus that affect whether or not it's going to come out the vagina. One of them, as I might have mentioned before, is the size of the head, okay? If the head is too big for the pelvis, it will not fit through, all right? And that is something that we call cephalopelvic disproportion. And you may see it on a chart as a reason for a patient having a cesarean section, all right? Cephalo, that's head, pelvic, disproportion, they don't fit. Or CPD, okay? All right. So, if we have too big a baby and too small a pelvis, then we're not going to have a vaginal delivery. Now, one of the things that does happen, fortunately, with our babies as they're trying to cram themselves through their pelvis is the bones of their skull are not fused. They are still loose and unattached, although aligned. These are suture lines, and hopefully you felt them on your babies. And then there's the fontanelles. I mean, there's a purpose that's very important for the baby, for these bones not being fused yet, and that is that it allows for brain growth, all right? So we won't have a brain grow to an adult size if we only have a skull that's this big. So it allows for brain growth. But the other thing that it does do is that these bones can overlap, and that basically allows them to mold or to form to fit through the pelvis. And so that's why you might have a baby that delivers that has a rather pointy looking little head. Has anybody seen a baby with a pointy looking little head? Yeah. Yes, yeah. And sometimes their heads look really, really pointy, and it's rather sad, but they go back in shape, you know, within about 24 hours, and just as an FYI, in case any mom wants to know if they should be patting the head or, you know, rolling the head on the bed to kind of make the shape come back, the answer is no. Okay, just leave the head alone. The head will get round, you know, in about 24 hours or so. So we do have molding, and that does help fit the head through the pelvis. So that's a good thing. Another thing that is important is what the presentation is. We call what comes first the presenting part. Typically the presenting part is the head. Why do you think the presenting part is the head? Typically. It's the heaviest, exactly. We are creatures of gravity. This is the heaviest part of the body. Heavy things go down, okay? So the head goes down first. Some babies don't understand gravity, I guess, basically. And so their heads don't come down first. And they're quite persistent in that, and they end up in some of the other presenting parts, one of which would be breech. All right, so that's butt first, all right? And breech comes in a number of different kind of varieties. There's basically butt first, like this, and then there's butt and feet, like this, like they're kind of in a yoga position, you know, they're coming out like that. And then there's what we call double footling breech, like this, they're just coming out like this, like they're on a slide. And babies, and my baby is losing its stuffing, I need to get a stapler. Or Band-Aids, maybe Band-Aids, or duct tape, ace bandage, something like that. But basically, breech babies, if it's a first-time mom, you're not going to see a vaginal delivery, okay? They typically will deliver a breech baby by cesarean, particularly if it's a first-time mom. If it is a multi-gravid mom who has delivered good-sized babies, nice average size, 7-pound babies or so, let me finish my sentence, hang on. And it's a healthcare provider who knows how to deliver a breech baby, then you might have a vaginal breech down the road, all right? Part of the problem with not delivering breeches by vaginally is that people don't learn how to do it. And so eventually probably all breeches will be delivered by cesarean section. Yes, ma'am?
How do they find out how the baby is by the ultrasound?
They can do it by ultrasound, but you can also tell by palpating the abdomen and doing what's called Leopold's maneuvers. Leopold maneuvers look at where is the butt, where is the head, where are the small parts, okay, and where's the back. And you have to press, and your mom might be uncomfortable, but the hard, knobby, round thing is typically the head, okay? The place where there's lots of kicking is usually the small parts. The smooth, long area is typically the back, all right? And from the back goes the butt. So a healthcare provider or a nurse that's felt a lot of pregnant moms' bellies knows how to identify what's coming first. And then also, someone doing a vaginal exam, when they go up into the cervix and they're feeling for what's coming first, they're either going to feel a skull, hopefully. They may feel our final presentation, which is what we call a shoulder presentation, and that's a baby who's trying to fit like this through the pelvis. They're kind of coming shoulder first. That is not a wise thing to do, and it doesn't usually work, so they would probably end up being sectioned. But if you do a vaginal exam and you put your hand up in the uterus and you're feeling around for something, if you feel a rectum and an anus, you know, and a scrotum perhaps, then you know that you've got a breech. So there's a number of different ways to assess that. Usually most moms these days, and you probably know this from Professor Walker, have an ultrasound during their pregnancy at some point in time. They often have them earlier, and babies can switch positions whenever they want. So they may be thinking it's a breech at 36 weeks, and it rotates itself at 38 and is head first. So that is something the healthcare provider would have to reassess. Yeah.
Can they reposition the baby if it's a breech position?
They can try. That is something that's called an external version, and it's done by the healthcare provider with an ultrasound and movements to try to force the baby to go in the head first direction. Sometimes it works and sometimes it doesn't. So, so we have to think about presentation. And then we have to think about lie as well. And lie is how is the baby lying in the uterus. And you can see here, up at the top slide, that is a longitudinal lie. In other words, the spine of the baby and the spine of the mommy are parallel to each other, okay? Now you can be longitudinal and be head first. You can be longitudinal and be breech, okay? And then this is what we call a transverse lie. This is a baby that's sitting in the uterus like this, right? Just like it's a little hammock, just like that. That's not a baby that's going to come out vaginally, so that would be a transverse lie. And you see unusual lies oftentimes when you have multiple gestation, when you have twins or triplets, because they're all kind of crowded in there, you know. But sometimes babies, you know, they get in a position they like, and they don't leave it. And so this mom would be sectioned. That mom would be able to deliver vaginally, okay? Attitude has to do with whether or not the baby is flexed or extended in its posture, all right? So we want to have an attitude of flexion for our fetuses. And so that's where we get the term fetal position, okay? If you think about fetal position, you think about all curled up, right? Curled up in a little ball. And that's basically what the fetus is they are curled up in a little ball. Yes, ma'am?
You said attitude is baby flexed or
Extended.
thank you.
Mm-hmm. So we've got an attitude of flexion here. We've got a fetus all curled up in a little ball like that. And basically what's really important for this is what the head is doing. And the head needs to be tucked like that with the chin on the chest. Because what that does for our fetus is it allows for the smallest part of the head to go through the pelvis first. I'm sorry. The largest, well, I'll show you another slide in a minute, so just scratch my last sentence. It allows for the most significant part of the head to go through the pelvis first, and I'll show you why in a minute. So we need an attitude of flexion like that. A baby who is extended like this, all right, so maybe they're trying to come down through the pelvis like that. Okay, that's what's called a face presentation. And sometimes we have a big enough pelvis and a little enough baby that it works, all right? They just kind of slide on through. But what do you think is the baby's face is going to look like when they have this? It's going to be pretty swollen, bruised, and smushed, yeah. And sometimes it's funny, you can even see with a face presentation baby, you can kind of see where the face has pressed against the cervix, there's like a ring. and there's bruising, and then behind the ring there's nothing. So they have this sort of like purple sort of face with a ring around it, and then the rest of the head has come through. So sometimes babies look a little funky when they come out, which is, you know, distressing to their parents, but not fatal at all. Now the last one is position. And the reason why I talked to you guys about position is because if you are putting a fetal monitor on a patient, perhaps in labor and delivery, if the nurse said, can you hook the monitor up, position is going to help you to identify where to put that monitor. Position has to do with how the fetus is coming through the pelvis, all right? And these two positions down here, right occiput anterior and left occiput anterior, are probably the most optimal and common positions for a baby to present in. All right? How do you tell position and why is it relevant? Well, it's important because position will tell you where the fetal back is. All right? And the fetal back is where you want to place a fetal monitor if it's an external monitor being put on the mom's belly. All right? The fetal back is the point of maximum intensity. That's the best way for you to hear the heart rate with your ultrasound and pick up a good tracing. And we'll talk about that during monitoring. But these two positions are probably the most optimal, all right? We've got the pelvis here, and so how do we identify position? Well, we have to know right from left, anterior from posterior, and head from sacrum, all right? So if I'm the mommy, and you think about it in terms of being the mommy, you have to be the mommy to understand position, all right? If I'm the mommy, this is my right side, and this is my left side. All right, this is my anterior, and this is my posterior. Okay, this is my fetus, and this is the fetus's occiput. And so the marker for a head-first baby is the occiput. The marker for a breech baby is the sacrum. All right. So if my baby is in an ROA position, that means that the occiput is on the right side of the mom's body. So here's the occiput right here. It's on the right side of my body, and it's anterior in my pelvis. See that? It's in the front of my pelvis, the occiput. So occiput is this area back here on our heads. It's the occipital bones. All right? So this would be ROA, right occiput anterior. So this would be what? What do you think that would be?
Right occipital posterior.
Right occiput posterior, because now the occiput's pointing towards the back side of me. Okay, it's pointing towards the posterior part of my pelvis. All right? So this would be what? What would that be?
Left occipital posterior.
Left?
LOP.
No. Where's my occiput? It's anterior in my pelvis, right? So left occiput anterior. This would be left occiput posterior, right? All right, then we have some middle here. Those are our transverse babies. Their heads or their occipits are pointing out to the side of the mom's body, like that and like that. That would be transverse. When the head is pointing posterior, like this, everybody can see, I know my pelvis is down here and my baby's, okay, so my baby's occiput is posterior in my body, if this is my pelvis, all right? When we have a mom who has a posterior position, they oftentimes have a lot more back discomfort because they have a hard skull that's pressing on their sacrum and putting a lot of pressure on their back. So they tend to complain more about back labor. And they tend to feel their contractions kind of centered in this area because they've got bony skull being pressed down on that area. And the sacrum, you know, is very well innervated. You know, if you've ever hit your tailbone, you know, if you've fallen on the ice or slipped and you hit it, you feel it, you know, and it is not fun and it doesn't go away. And so we have these moms that have a lot of back labor and a lot of back discomfort that we have to deal with. So position, again, why it's important to you beyond just sort of understanding it is if I'm putting a fetal monitor on me, okay, and my baby is in an LOA position, which this baby is, where am I going to put the fetal monitor? I'm going to put it right there, aren't I, on my belly, right? Okay. And so again, if you do Leopold or a version of Leopold maneuver, just feel the belly. Again, you're feeling for the smooth, flat part of the uterus. That's the back. A way to ask is to say, tell me or show me where the baby is kicking you, because the kicks will be more localized on the side where the small parts are, all right? So this would be where I would feel the back. This would probably be mostly where I feel the kicking, okay, or the pressing or the, stretching and stuff. All right. Okay. Any questions so far? I was going to take something about posterior, but I can't remember what it was. No, I was going to tell you something about sacrums. I had a patient once that had broken her coccyx, basically, when she was a kid. She had fallen, and so it had just fractured right where the sacrum and the coccyx meet. And obviously, there's not a whole lot you can do about that kind of injury. So it had healed, and it evidently healed and formed bone spurs and things like that. So she was in labor, unfortunately, and she had a posterior position fetus, and she was in excruciating pain, and nobody, and obviously you can't x-ray a pregnant woman to look at their coccyx. So, the healthcare provider didn't have any idea what was going on with why she could not get her pain covered by her epidural, and she just had this back pain that was just localized right there. And she finally said, about 8 centimeters or so, I did break my tailbone when I was a kid. Oh, well, that's probably why. And I think she did get evaluated later on and had bone spurs and things like that. So that back pain can be quite significant and quite real. Now, something that we're going to talk about when we talk about labor, but I'm going to talk about it in terms of the fetus right now, is something we call station, right here. And remember I said that one of the important, yes ma'am, I'm sorry.
Does uterus tilt have anything to do with presentation or not?
With presentation?
Well, or just, how the baby sucks up.
In terms of whether or not it's head first or breech, probably not as much as how the patient's laboring. Okay? Although it may. That's okay. Do you want to just come in and say it or what? That's okay.
We're going to start, for those of you doing this here, at 1:15. We'd like to start sooner if possible. So if you can just gather by 3:42 with your lab coat as soon as you are able to after class, we'll get started and then we'll get you on the road. Okay?
Okay, 1 o'clock, everybody here. That's okay, that's okay. I knew you were coming, I was waiting. Okay. So perhaps, but probably not in most cases, Patty. I would say that would be the answer. Okay. One of the important things that we mentioned, yes ma'am?
So the baby is posterior, where do you put the monitor?
Well, that is a tricky thing that we'll talk about when we talk about monitoring. You're right, because the back is on your back, and you don't monitor the back. So the monitor might be cheated over to the side a little bit, like this, okay? So monitoring and putting a monitor on can be kind of challenging when the baby is posterior. And you may find that you're monitoring here versus monitoring here, okay? Or it may be that your healthcare provider gives up, and once membranes rupture, they'll put on an internal monitor, and then you won't have to worry about it. So, yes ma'am?
They did say in the book, I read some of it, but they said if you hear a heartbeat that's not really fast, it may be the mother's heartbeat.
Right, well that is
So
true as well,
you need to
yes.
for a faster heartbeat.
Yes, that is true, yes. You do not want to pick up either the placental swish or the aorta, but you should be able to tell the difference, okay? The placental swish sounds like a whoosh, 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 okay? Whereas the fetal heart rate sounds like a funka, 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 funka. And the aortic beat is going to be half that of the fetus almost, okay? So it's going to be more like whoosh, whoosh, whoosh. And it sounds swishy too, so. All right, so anyway, back to station. One of the important things that we need to determine is the baby coming down through the pelvis into the vagina. And station is the assessment that tells us that, all right? And it also tells us whether or not the baby is going to fit through the pelvis, all right? So to understand station, let's look at my fractured pelvis here. All right, here's my pelvis. There's that coccyx we talked about, sacrum. These two little points right here, you see those? Those are called the ischial spines, all right? They're right there, those little protrusions, okay? See them right where my fingers are? Okay, that's the narrowest part of the pelvis, okay? That's the smallest gap, all right? And the baby has to fit through this narrowest part. And it has to fit the biggest part of its head through that smallest part. All right, so that's the pelvis. Someday I'm going to have to get my pelvis repaired. Okay, let's look at the head now. This is the head. Okay, this is the biggest part of the fetal head. See those little bumps on the noggin there? Okay, those are the parietal bones. We all have them. We feel them on our heads. They protrude in different ways. But this is the widest diameter of the fetal head. It's called the biparietal diameter because it's between the two parietal bones. That's the biggest part of the head, and it has to fit through the smallest part of the pelvis. All right? Come here, Abe. Just do me a favor. All right, hold that right like that. Thank you. Okay, so when, all right, now see, I have an attitude of flexion. See how my chin is tucked on my chest? All right, I am cruising through the pelvis. I have a little bit of a stiff spine here. When my biggest part of my head, okay, is at the smallest part of my mom's pelvis, I am at what we call zero station, okay? Zero station. My head is engaged. That means that I'm going to be able to come out the other end, all right, barring unforeseen circumstances where my heart is doing something funky or things like that. So this is what we call assessment of station. And when biggest part of head is at smallest part of pelvis, okay, that's called zero. Above zero is -1, -2, -3. Below zero is +1, +2, +3. Thank you, sir. You can type now. Sorry. Okay, so we can see that up here in this picture, all right? This baby, the biparietal diameter is kind of like right above the ear, and at that red line is my ischial spine. So this baby is at kind of like -4 right now. So it's still floating up here like this, okay? Okay. So when it gets to zero, it's engaged, zero station, and then it comes further down.